Hey, welcome to the arterial blood gas sampling PowerPoint. So this one should be pretty short, so we'll see how long it goes. Hopefully it won't be too bad, but let's start with why we obtain arterial blood. The big thing here is to determine if this patient has enough oxygen in their blood to go to the tissues. Like, is there enough oxygen in their blood to keep their organs alive? So that's where we're looking at the pressure that's in the plasma, the PaO2, and the saturation, which is how much oxygen is hanging on the hemoglobin molecule. So if you remember from our respiratory, from our first class that we had together when we were looking at pulmonary A&P, we were looking at how much pressure there is and how much saturation there is, and we need to make sure there's enough saturation, but we also need to make sure there's enough pressure, because remember, PaO2, even though it plays a small role as far as carrying the an amount of oxygen, it starts the cascade that pulls oxygen off of the hemoglobin to the tissues. So we need both a good perfusing PaO2 as well as a decent saturation for someone to survive, to have their organs stay alive, including the brain and the heart. Besides oxygenation, we need to determine if they're ventilating. So we need to see if they're hyperventilating, hypoventilating, what's their balance there? What are they in a state where they're in an acute phase that's mild? Is it just begun? Are they in a potential to fatigue and tire out, or now are they in complete respiratory failure? So when we start to go into things like intubation parameters and what to adjust things on mechanical ventilation and BiPAPs, we're going to have to start looking at their ventilation, and the blood gas is still the classical and best way to see if someone is ventilating. If you have a central line, we can get a CO2 off the central line, but remember, if someone has a high metabolic rate, like they have sepsis or some sort of acidosis going on, then that's going to actually throw us off and not determine how well their lungs are actually functioning. So determine oxygenation and determine ventilation, and finally the acid-base balance. So this is going to be a function of the CO2, the bicarbonate, pH, and we talked about this before. So when we're looking at this, especially people that have renal failure, chronic renal disease, chronic kidney failure, things like that we're looking at, we've got to look at their pH, right? And so that's going to be one of the big things. Are they compensating to the point where they're okay, they're in a normal pH range for them, or is their pH range dangerously high, above 7.5, or is it dangerously low, below 7.20? And that can vary from neonate through adult on what we consider survivable, but in the adult population, we're usually 7.20 to 7.50, somewhere in that area. People can survive in lower and higher, but those are just the general rules. Same thing with PO2. Usually try to keep that PO2 above 55. In that saturation, hopefully above 85 in a lot of survivability scenarios. So you do need to know the ARC CPG's clinical practice guidelines for this. In my book, it's on Egan's page 369. If it is not in your book, because I have a different edition than you, there's this website called aarc.org. And if you haven't gone there before, welcome. ARC.org, you can actually look up clinical practice guidelines. So the American Association for Respiratory Care actually posts guidelines on suctioning. They post guidelines on all these other things. So please go to the AARC website, especially if you cannot find it in your Egan's book. AARC website, search for clinical practice guidelines or CPGs, and it should take you right there as well. That's always a good resource for you, for sure. All right, hazards of blood gas. So this can freak a lot of people out, and that's understandable. I absolutely get it. I remember being so nervous before doing blood gases. Even with our fake arm in the lab, I was like shaking, so nervous. Gets to the point where now I've done probably easily over 1,000 blood gases in my career. So you think about, hey, if I do 8 to 10 a day and you work 3 days to 4 days a week, and then you work 52 weeks out of the year, right? Those things will start to add up. And there's some days where you're doing more and more blood gases, the more sick patients you're taking care of. And so you're going to build up that blood gas skill pretty easily, pretty fast. And so you'll get pretty good at it. So some of the hazards that you have to look at is the spasm of the vessel is going to be one of the big ones. Because there's nerve intervention to your arteries, now remember there's not to veins, but there's to arteries, you can have a spasm to the vessel itself and cause the vessel to constrict, and therefore makes it a smaller target, which means it's harder to hit. And also when it's constricted, when the artery is constricted, that means the wall of the vessel is now thicker, because remember, all those things move closer together when it constricts. And so now it's harder to pass the needle in through the wall of the artery and into the bloodstream itself. So it makes for a very hard stick. So the more nervous or anxious a patient is about the procedure, the less likely your chances are of probably getting it because of that spasm. So you are just Mr. Calm or Mrs. Calm or whoever calm you want to be in that room, just to be like, hey, we're going to do this procedure. It's going to look at your pH, it's going to look at your oxygen levels, it's going to look at how your renal function's doing. It's going to give us a lot of important, valuable information, and usually we're not going to do this unless we absolutely have to. So, and that's where you're bringing that calming presence that could absolutely happen. If the patient's in a lot of pain, of course they're going to be in that fight or flight, and that'll cause vasoconstriction as well as arterial constriction too, right? That's that sympathetic where their blood vessels will constrict because they're releasing all that stuff. Clotting and bleeding, I'll put both of these on here. Clotting and bleeding are big ones here. Clotting and bleeding, they can have a clot that forms that can go into their system. Sorry. Travel around their system. Same thing with bleeding if they're on heparin or blood thinners, if they have atrial fibrillation and they're on blood thinners. If they're some of these people have very low platelets, and especially depends on what diseases they have going on. So before you go draw a blood gas, we want to look at their INR, which is their ability to clot, platelets, which should be over 100,000. You guys should know these numbers so you know whether or not it's safe to do the blood gas, or how safe that procedure potentially is, or how dangerous that procedure potentially is. So clotting and bleeding are some of the big ones, because you're stabbing or you're puncturing an artery. Those are high pressure vessels. That's why they're such thicker vessels. And so if they're on blood thinners, there's a big chance for a bleed out if you do not do this appropriately. So I'm not trying to put fear or nerves. I just want to make sure that you are holding pressure, that you're checking for clotting issues for these patients. If they're on DIC, if they're on heparin, if they're on anything, they have low platelets, if they've had a lot of blood loss lately. So that way you know that there's potential for hazards with that patient more than not. And of course, one of the most common ones is going to be a bruise, a hematoma that shows up. So that bruise can easily show up, especially on your generationally advanced individuals. That bruise can easily start to happen. All of those patient populations will have the bruise that show up because their issue is their skin is just not able to sort of hold or to clot off as fast. So bruises are very easily, it's a very sad thing, but it's actually one of the more common hazards that you'll still see. Hemorrhaging, we talked about that, especially if you don't hold pressure after the puncture. That's going to be one of the big things. And also you can have what's called a lacerated vessel or trauma to the vessel itself. These are very, very bad things that can easily happen. You can even look at cadaver pictures on Google Image of lacerated COPD vessel arteries from their COPD that got repeated blood gas after blood gas after blood gas, and then you can see they got a bunch of lacerations, a bunch of scar tissue that builds up that sort of makes it all crunchy in there. Pretty bad stuff. You can also have arterial occlusion that easily happens. Vasovagal response can easily happen. That's where they go into this psychogenic shock, which then can cause the spasm of the vessel, right? So you're looking at, hey, I'm nervous about this test, or I'm nervous about this ABG draw, right? And then somehow that gets their nerves going, and now they have an issue with a vasovagal that causes their artery to sort of spasm. Or if they're in pain, that pain can easily send the pain receptor response, that fight or flight, that causes that vessel to spasm, right? So all these can lead to decreased blood flow to the tissue, which ischemia and necrosis can ultimately go. So if they don't have collateral perfusion with their ulnar artery, then they can easily lose their hand ultimately down the road. It's not something that happens very regularly, understand that, because we always have to test and make sure that they have collateral perfusion before we stick them. Thing there. All right, sites. And so what you guys need to know are these primary sites for an adult. The radial artery is going to be your primary place. So that's this guy right near the thumb, or this lady right near the thumb here. So that's what you're looking at here. So that radial pulse site location where you would feel for a pulse or a heart rate. That's where the primary site is, because you have the ulnar artery. So this is the radial artery here, and then here's the ulnar artery that also gives collateral perfusion to the hand. So if for some reason you were to lacerate and destroy the radial artery, once again, I'm not trying to put fear into you, but if something were to happen to the radial artery, they would still be able to have perfusion to their hands with the ulnar as well. So there's a lot more collateral perfusion. The next site is going to be the brachial artery, located sort of on the inside of the elbow there. You could probably feel it on yourself, that inside of the elbow, unless you got massive biceps, which I don't. Then you should be able to feel it on the inside of your elbow. You can feel this really well on kids, generationally advanced individuals as well. This is sort of a secondary location. There is still some collateral circulation. Here, not as strong as in the ulnar to the hand, but your primary site is going to be the radial artery. It's more superficial at the radial artery too, so you don't have to go near as deep into their tissue. The angle is a lot better for the radial artery puncture as well. Your final site is going to be the femoral, and I wish I could give you guys my whole thing. So if you know the hook 'em horn sign, where you have your finger, your pointing finger and your pinky finger, if you stick them out and you put your two middle fingers, so your ring finger and your middle finger, bend them down. So that's about the distance between the iliac crest and the femoral artery. So if you lay down flat and you feel with your pinky finger your iliac crest, so you feel that bone in your hip, where your first finger hits, or your pointer finger, should be roughly in that sort of crest there of the leg, where that iliac crest, so where that sort of crease hits in your leg, you should be able to feel the radial artery somewhere in that site. So this, not radial, the femoral artery in that site. So when you feel for the femoral artery, this is something they might have their hands on while they're doing chest compressions, sort of feel how strong the compressions are, how effective the compressions are doing. But this would be a site that you only usually access during a code situation. Some hospitals don't let RTs even draw from the femoral site. Usually this is a 90-degree stick with a large bore needle. Because all this blood shunts away from your brachial and your radial during a code, probably the best site for blood gas is going to be, so code blue, is going to be this femoral artery area here. So femoral artery during a code, radial brachial, usually more for standard patients. As far as arterial lines go, radial and brachial and femoral are options. So the radial site, it's pretty superficial. That's one of the reasons why it's the preferred first choice for blood gas. Superficial, easy to feel, because remember, you can't see the artery. Unlike the veins where they could put a tourniquet on, most patients, you cannot see the artery. Very, very rare you can, unless you're looking at like the little super premature babies in the NICU. So it's very stable. You have sort of a bunch of tendons in that area because it's the wrist. So it's very stable. It's not going to move around on you. So unlike a vein that rolls, this one just has a very thick outer layer. Arteries have a very thick outer layer. So it's going to be something where if you just go in slowly, you advance your needle slowly, you may actually push the artery out of the way and not even puncture it, even though you have a needle going in there. That's how thick that thing can be. So you need to make sure that when you do advance the needle, it's a firm, steady advance. It is not a slow advance. It is a firm, steady advance. Otherwise, you probably won't get it. The other thing here, it has good collateral circulation via the ulnar artery. There's a lot less pain in this situation because it's more superficial. There's a lot less nerves in the radial site compared to like deeper in the elbow or in the femoral, of course. So a lot less pain with the radial site as well. It's not adjacent to any large veins like you don't have with your elbow, and especially your great saph that's in your leg that's next to your femoral. So you have a lot of advantages with the radial site. So you should remember these. It's an important slide. Brachial sites, fairly good collateral circulation, so they won't lose their whole hand if you blow a brachial artery, or if it's not. It's just not going to be as optimal as the radial artery. Good circulation, inferior and ulnar arteries. So you are going to be closer to the median nerve in this situation, which means there is a bigger potential for pain associated with a brachial stick than a radial stick, as long as you're adequately if you have adequate technique. There's a lot less pain associated with a radial stick than a brachial stick. Big nerve in that elbow there. You hit it, you're going to know about it, and then you're going to have to watch where the other hand is because you might get it. The femoral location, like I said, this is the best site for code. It's your last resort site. So there is no collateral circulation. So if something were to happen and you lacerate the femoral artery, there will be no blood flow to the whole lower part of the leg. So no part to the thigh or the lower part of the leg, of course. So they would, in theory, lose their whole leg. That's why at some hospitals, RTs are not even allowed to do femoral sticks during a code. It's a physician thing. There's a lot of hospitals out there where only the physicians can do the femoral jaw. Swedish, we were able to do the femoral jaws there because we had training and all that stuff on it. Last resort site, very, very deep. It's close to the great saph and nerves, especially. So there's a lot of risks that can be associated with it. During a code, we like to see where their blood gas is and rule out what's called H's and T's. You guys can look that up on your own. So we're trying to rule out H's and T's in ACLS, if you want to Google that. H's and T's, and then we're looking at other things like ionized calcium. We're going to run those labs for electrolytes. We're going to run them for a lot of stuff. So a lot of stuff is going to be run on that blood gas, and so that's going to be the best site to. The Allen's test. So there's the regular Allen's test, which is not done anymore, and then there's the modified Allen's test. The modified Allen's test is what I'm going to be primarily testing you on. The Allen's test says we're going to include the radial artery for 3 minutes. We're going to look at the color of the hand. We're going to include the ulnar artery then for 3 minutes, and then we're going to look at the color of the hands. Right? Did they pink up? Right? If it's positive with the radial artery occlusion, we would see. If they were negative, there is no occlusion, no color change. So we want to see the Allen's test is not something that's done really much anymore. Modified Allen's test is something that we do now currently. So modified Allen's test says we're going to occlude the radial and the ulnar artery. So we occlude both of them. We put our finger and we put pressure on their wrist over both of these, and you can do this on yourself right now. We're going to have them open and close their fist. If they're on a ventilator and they're not with it, they're not following commands, you can just raise their hand up a little bit, right? Let the blood sort of drain through the veins so that way it gets the blood that's in there out of there. Open the hand and let go of the ulnar artery. So this simulates that the radial artery no longer has blood flowing through it, but there's blood flow through the ulnar, correct? Because you let go of the ulnar. So if you let go of the ulnar and their hand pinks up, that's a good sign, so it should pink up within 10 seconds. It's considered positive, right? There's no ulnar artery occlusion. In other words, the ulnar artery is a good alternate route, and we should be safe to do the blood gas on this wrist. It's negative if you don't see color change in 10 seconds. Then we're going to go from the patient's right hand to the patient's left hand and do the modified Allen's on that as well. So the modified Allen's test is something we always had to chart. I always did what was called the modified Allen's test, where I'd put a pulse ox on the hand that I was testing. So if you have one of those finger pulse oxes at home, put it on your finger. Try it now if you can. And then occlude both the radial and ulnar artery on that same hand that you have the finger pulse ox on. And then you should get no signal, right? It should go away. And then you unocclude the ulnar artery, and then you should start to get a signal back. Well, that means there's good collateral perfusion, and therefore you should be safe to do the test. And even if the radial's blown for some reason, then you still have good collateral perfusion. So the patient needs to be cooperative for the modified Allen's test, especially to open and close their hands. Previous arterial cannulation may obliterate the pulse. In other words, if they had an arterial line in place, they may not be able to feel it. They might have scar tissue there, things like that. Patients that are in shock, where it means they're massive vasodilation, or if they have poor perfusion, let's say they've lost a lot of blood and they were a trauma patient or something like that, are pretty difficult to sort of see this with the Allen's test. The wrist or palm burns make the interpretation difficult, so burn victims make this incredibly hard. And so that's why I would use the pulse ox too, because it's very subjective, looking for color change. That's something that from person to person can be interpreted differently. But if I have a signal, I lost the signal, and the signal comes back again on a pulse ox itself, then I know I'm usually doing pretty good. That's why I always did my pulse ox version of the modified Allen's test. So little trick, if you wanted to use it, go for it. Results are inconclusive if blushing is delayed 10 to 15 seconds. So in other words, their perfusion, collateral perfusion is still there, it's just delayed. So that means it's inconclusive. If in this case, it would behoove you to move to the other wrist and check the other site. Alternative sites, the ulnar in theory is also an alternative site. However, this is it's much harder to stabilize, it's deeper, and it's more subject to having a clot as part of it. So it's not really considered something that we would actually use. So in my whole practice, I've never had to do an ulnar, even if we could not get a radial or brachial or femoral, like we've never had to do an ulnar. That's just not something that was part of our lexicon because there was more risks associated with it. Brachial location and dorsalis pedis. The brachial location we already talked about. The dorsalis pedis, top of the foot, for spinal cord injury patients or for quadriplegics or tetraplegics. All those people, not great if someone has diabetes, right? Bad idea for those patients. In theory, you could do the top of the foot as well. I've only done a couple of these. This is not something I approve of greatly out there, so we'll talk more about that later. But for now, if you're out there, and I would say that's not high on your list of options. Femoral location, of course, during a code or rapid response, something that usually is either done by the doctor or highly trained RT. So femorals, hopefully you guys get to see that. Of course, you have YouTube yourself, you can look at that as well. All right, so we've covered sites, so let's look at things that go on with the blood gas itself. So just as far as the equipment and troubleshooting, if there's things like too much anticoagulants or too much heparin in the syringe, so there's heparin in the syringe, so the blood doesn't clot up after we draw it, so we can take it to the lab and we can run the gas. So if there's too much, it will actually increase the pH, so the pH will get more alkalotic, or the pH will get more basic, right? The CO2 will decrease, and it can either be an increase or decrease in their PO2, sort of depending on what's going on with their gas results, what's in their blood gas, what's in their blood to begin with, can either increase or decrease their PO2. So the big thing here is you need to remember if there's too much anticoagulant or too much heparin, right, in that syringe, like a little ball of heparin is in there, it will increase your pH, right, alkalotic, and decrease CO2. Well, if your CO2 is decreased, what's going to happen to your pH? It'll go up, right? So as long as you remember that it'll turn them alkalotic with the CO2 and pH, you're good to go there. But you do need to remember that the blood gas could be altered in its results if there's too much heparin in theory in that syringe. That's why you never want to draw super small amounts. Super small amounts will actually increase their pH and decrease their CO2 and make it appear that the patient is in a different acid-base balance than what they are actually in. If there's too little heparin, then you're going to have an issue with clotting in the syringe itself, which means they're not going to be able to run the gas, which means we're not going to get the information, which means you poked a hole in someone's artery for no reason, and now you have to go do it again. Trust me, patients don't like it when you have to redraw blood gas. So the big thing here is It will help lubricate the inside of the syringe, so we're going to have that in there. It'll anticoagulate, so it'll help prevent the blood from clotting, but it helps lubricate the syringe, so that way when we have the arterial pressure pushing it, it will actually push itself out, so we don't have the opportunity for an air bubble to be introduced. And air bubbles in a blood gas syringe are also bad, because that means atmospheric PaO2, P big AO2, atmospheric PaO2 is higher than blood PaO2, right? Remember, we're talking about this back in pulmonary A&P. And so remember, it's like normally like 149 or something like that. So if you have a really high PaO2 in an air bubble, then that will artificially increase the PaO2 of the blood. So that's not very helpful at all. So when we're looking at anticoagulants, 0.05, I'll say that again, 0.05, 0.05 milliliters will anticoagulate 1 ml of blood. So if you're going to draw 1 ml of blood, you need 0.05 mLs of heparin. So most of the syringes out there are pre-heparinized. You just need to make sure you draw a minimum of, I think, like 3 to 5 mLs overall. So you won't have to do this, but if you do have to do this on your own, and I would expect these to be on some sort of recall and or memory recall document of some sort in the near future. 0.1 ml, 0.1 ml will not affect values of 1 ml of blood. So when you're looking at a 3 to 5 ml syringe, it contains 0.15 to 0.25 mLs of dead space of the syringe. So that's how much of the syringe is taken up by just sort of that heparin. So when you're doing a blood gas, an arterial blood gas, 2 to 4 mLs of the sample will contain 0.05 mLs of heparin for 1 ml blood, but not more than 0.1 ml per ml of blood. So that means we're in a safe range here. So if you're only able to draw half of a ml, so 0.5 cc's of blood, that means you have a high heparin to blood volume, which means that can throw off your blood gas. That's what we're ultimately getting at here, is did I get enough blood in this sample for it to be an accurate test to go run, right? That's the whole thing here. You do need to memorize these or get these down for this next exam, but that's what we're looking at here. Okay, venous admixture, we did talk about this a little bit in pulmonary A&P. So this is recognizing by no pulsations filling the syringe or dark red color. So when you go in for the blood gas into the radial artery, hopefully you'll go into the radial artery. Let's say you poke them and you start to get blood coming back in there, but it's dark. And you don't notice it sort of pulsing into the syringe. You don't see it going with the pulse that you feel. You might have hit a vein. So there are many RTs like, I got blood. And I'm like, yeah, it's venous, but we got blood, right? That is not a blood gas that you can use because it's from a peripheral vein. If you're going to do a venous blood gas, it needs to be from a central line, something that's very close to the vena cava, right? That's why central lines would be the ideal location here, and or a Swan-Ganz catheter, the distal tip of the Swan-Ganz catheter. But if you do not see pulsations, it's very dark, it does not flow really easily into the syringe, odds are you probably hit the vein and you're drawing a venous blood gas. The PO2 in this blood gas is going to be very low. You do not, if you hit an artery, even on a patient that's hypotensive, like someone that we're doing compressions, chest compressions on, CPR on, you still do not need to aspirate. You do not need to pull back on that syringe. You still should have adequate pulsing, even with compressions, that should fill it up with pulsing. So if you have to pull back, odds are you are in a vein, right? And so that's not something we can use. That's a whole big thing. The other thing to look at here to know if you have a venous stick, if you're unsure of it for some reason or another and you run it, check what their saturation is, right? Especially if you use my pulse ox version of the modified Allen's test. what was their saturation at the time of the blood gas? If their non-invasive saturation, let's say, was 95%, and you draw blood gas, and it shows their SpO2 at 85%, then you know you probably got a venous gas because of the big saturation differences there. Normally it should be within like maybe 3 of the pulse ox if you have a good perfusion on that patient. So that's one way of also knowing if it's a versus an arterial gas. Anaerobic conditions. This is something I have to look at. So room air has a PO2 of 150 millimeters of mercury. I thought it was 148 to 149 in there. I'll have to check my sources. So PO2 close to 150. The CO2 in room air is less than trace gas, so it's very, very small, so less than 1 millimeter mercury. It's actually 0.21 millimeters of mercury, so it's almost nothing. So PiO2 is pressure of inhaled oxygen, PiCO2 is pressure of inhaled CO2. So why am I talking about these? Well, there's an air bubble in a blood gas. If you do not aspirate any air bubbles in the blood gas, so after you've completed the gas, you're holding pressure on the wrist. If you do not get the air bubbles out, that will change things like the pH and the CO2 and the PO2 of the blood gas, which means those results aren't valid, which means we don't really know what's going on with that patient, which means you're going to have to go in and redraw it. So that's going to be a big deal. So decreased CO2, obviously, because CO2 in room air is virtually almost nothing, right? Because when we're talking about CO2 in room air, 0.21 millimeters of mercury. So the CO2 of the blood gas is going to drop drastically, and their PO2 of the blood gas is going to increase, right? So you're going to see an increase in their PO2, a decrease in their CO2. Because of their CO2 decreasing, what do you think will happen with the pH? Well, because the CO2 is decreasing, the pH will go more alkalotic as well, right? Less carbon in there means it's going to be less acidotic. So the whole blood gas will be inaccurate, and we may make poor clinical decisions based upon that inaccurate blood gas. So you need to make sure it's good. So PO2 will increase if the original value is less than 150. And if their PO2 value will decrease, the original value is over 150. So the second part here, I wouldn't remember as much, but let's say we have a organ donation patient. So we're taking care of a potential organ donor, and we have to take his PO2 up to 300 to help hyperoxygenate his tissues and organs, especially his kidneys. And so if we draw a blood gas on him and his PO2, let's say, is 300, and there's a bubble in there, then his PO2 will actually drop because his value was over 150. So it's going to decrease because the value of room air is roughly around 150. So that's what that part is. I wouldn't worry as much about this guy. I would worry more about this one, right? Very rare situations, you're going to have their PO2 above 150. All right, delays in running the sample. You forget it's there. Those are pretty bad. If the blood continues to metabolize, it's going to continue, which metabolism is consuming oxygen. It's going to continue to consume oxygen and produce CO2. So that means it's still warm, it's still metabolizing. So that's one of the things that you have to worry about. So when the patient has, if we don't have the ability to go put it right away into the blood gas machine, we usually have to put it in an ice bath to take it over there to stop or to slow down blood metabolism. So that way we get an accurate view of both their PO2 as well as their CO2. So we get an accurate value of both of those. Decreased temp and increased temp. So decreased temp, decreasing the temp will decrease the metabolic rate. That's why we put these in a little bit of ice bath. We don't want to freeze them. We're not going to put it in a freezer. You're not going to put it in a refrigerator. You're going to put it in a bag that has an ice sort of slush to it, or follow the policies of that hospital. They do make glass syringes still where you don't have to do that because it actually stops the metabolism or slows it down as long as you run it within 15 minutes or so. So just pay attention to the hospital you're at. But do not freeze it, right? It's not there for frozen. So if
you freeze it, that will actually decrease PO2 and increase CO2, and the pH will look more acidotic. This is a whole bad situation. So you want to cool it so it doesn't continue to metabolize, but you don't want to freeze it. Ultimately what you're looking here. So temperature correction, this was all over the board exams. I'm sure it's still in the lexicon. Last time I took the RRT, it was still in the lexicon. It was still in the syllabus. So you're looking at the blood gas analyzer is assuming the patient's at 37 degrees. So they're assuming the patient's temperature. So when we go to draw blood gas, one of the things that we'll check is what's their temp. If they're cold, they're hot, we need to know because the solubility of gas changes with temperature. So remember that we talked about Dalton's law and Fick's law, which says pretty much everything will affect diffusion. And so that's going to affect gas solubilities with temperature. So we have to look at with temperature correction, we have to know what temperature the patient's at. So if the patient's temp is high, that means they're right shifted. There's less affinity for oxygen to attach itself to the hemoglobin molecule. So they'll have decreased oxyhemoglobin and increased PO2, right? It can't attach itself to the hemoglobin, so it's just going to stay in the plasma. It can't park on the hemoglobin, so it's going to stay in the street, right, in the plasma. So we're assuming the street's the plasma here. So it's going to park in the street because there's no parking spots on the hemoglobin molecule. So PaO2 in the blood will actually is lower than what's actually being read. So the total oxygen content, the CO2 does not change overall, but we're looking at an issue here where it can affect how it's sort of looking in their blood and how oxygen's transferred in their blood. Remember, if a patient has an increased temp, that's one of the things that can cause a right shift. So if you're hypermetabolic, that will cause a right shift. That means you're not going to be able to deliver as much oxygen to your tissues. Now, normally it's normal for you to be right shifted at the tissue level because that means there's oxygen that's coming off of the hemoglobin and CO2 that's loading onto the hemoglobin to go to the lungs to get it out. So if we have that right shift there, it's okay. If you have the right shift at the lungs, that is not okay. So if their temperature is too high, their ability to transport oxygen is going to be a lot lower. If they're hypothermic, we have someone that's cold, someone that has an exposure issue. Let's say we have a hiker that was found in super cold conditions. They'll be left shifted. They'll have an increased affinity for oxygen to bind to their hemoglobin, to park on that hemoglobin molecule. So they have lots of oxyhemoglobin, but their PO2 is low. Well, this is dangerous, right? Because if the PO2 is what starts the cascade to the tissues. So if the PO2 is low and that pressure gradient is low, then there's no real meaning, there's no real desire for the oxygen on the hemoglobin molecule to go off into the tissues where it needs to be used. So it's just going to love and stay with that hemoglobin molecule because there's no desire for it to ever leave, right? You need that PO2 to start the cascade to pull that oxygen off the hemoglobin molecule to get into their tissues. So the oxygen tension, their PO2 in their blood will be higher than what's actual. So their total content, CO2, will not change, but their ability to transport oxygen in both of these situations is hindered. So even though their CO2 is good, their ability to use the oxygen, bad. I'll say that again. Even though the transport of oxygen is good, their ability to use it is bad. So for a left shift or a right shift, you need to look at what's causing it. If it's hypothermia, hyperthermia. The therapeutic intervention in the meantime is to give them more oxygen. We obviously need to find out what's causing it. So temperature correction. So when we take this blood gas, let's say they're cold or let's say they're hot, we need to correct for the temperature of the patient due to its effect of the curve. So patient's temperature that's greater than 37, we're going to have the machine PO2 is going to read lower than the patient's actual PO2, so we might think they're more hypoxemic than what they're actually at. Same thing if we have a patient's temperature. If the machine PO2 will read greater than the patient's actual PO2. So we're going to have a decreased temperature will cause a left shift, which means we have more affinity and a lower PO2, right? And so increased temp, which will cause a right shift, will mean decreased affinity, which means we have a high PO2, right, high PO2 with the right shift, but a low saturation with the right shift, right? The machine doesn't know that they're right shifted or left shifted. It doesn't know. You have to tell it what temperature the patient is. So this is the whole bullet point here. You do need to know what happens to the PO2 if their temp is high or low, right? I will test you that. But if you don't tell the machine what the patient's temperature is, it will alter the blood gas oxygen results. And that's a big thing. So big thing here, get a temp when you get a blood gas. Chart it, right? When you go run it, you need to tell the machine this is what the patient's temperature is, so that way you get an accurate PaO2 reading. Yes, that's the big bullet point here. I know it's a lot of stuff to go through, but the temperature correction is sort of a big thing here. Analytical errors. So how do we prevent errors? How do we prevent from making some of these mistakes? Big thing, we're going to expel the air bubbles. That's why you'll see us tap the syringe a little bit, sort of flick the syringe. That's going to get some of the bubbles to move their way up, and then we're going to be very gentle in expelling it. We're going to mix the sample. This just does not mean shaking at all, right? This is not a shake weight. This is not something that you just shake around. You're going to roll it in your hands. Literally just roll it back and forth in your hands and just sort of mix that heparin and the sample together. We're going to place it in a sort of an ice slush. Like I said, when you go to do the blood gas, you're just going to have this little baggie that's going to have a little bit of ice in it. And by the time you're done drawing the gas and the sample, it should be a little bit slushy, especially if you're not analyzing immediately. Now, if you have the ABG machine within 20 steps of where you're at, that's a whole separate thing, right? We don't want to lose it, but usually most places you're going to still do the ice slush. Get the patient's temperature. That's what that whole last slide was about. That's what you had to listen to me all that about. Get the patient's temperature, otherwise their PO2s are going to be off. If the patient's hyperthermic or hypothermic, it'll throw off the accuracy of the PO2s. Well, what's one of the indications for blood gas? Looking at their PO2s, right? So you don't run it immediately. You need to put it on an ice slush, right? That's going to be one of the big things here. Sampling itself, make sure you have an order. Doctor's order must be there, or a protocol. It must be part of the order on the protocol. Anticoagulants and bleeding time. Is the patient on any anticoagulants? Something you can ask the care team or look on the MAR if you're familiar with things like heparin and so on. Coumadin, heparin, all those things. Do they have a bleeding time? Usually that's like 6 minutes. Or PTT or PT-INR. Those are all things that you might want to look at before doing this. What's their diagnosis? Are they looking for renal failure and so on and so forth? Why are you doing the blood gas? Hemoglobin. Are they low on their red blood cells, H&H? So that's something that we'd have to look at. Temperature, so especially if the hemoglobin's low, their ability to, their saturations will be good, but their actual oxygen transport will be low because there's less parking spots altogether, right, if their hemoglobin's low. What's the patient's temperature? Like I said, every time you do blood gas, you need to get what their current temperature is. How much oxygen are they currently on? Right, that's a big thing to chart because it's going to tell you how much oxygen they were on, if it's undercorrected, corrected, or overcorrected. Vent parameters, how much pressure are they on, and how much FiO2 are they on, right? Those are the big things we look at with the ventilators. Are they have any allergies, especially to things like the Band-Aid, right? Anything to like latex or anything like that. Anything we're going to hold pressure, betadine for wiping off the site. Recent changes in their status, if they've been suctioning the patient's lungs, that's obviously can be a change there because you're sucking out gas out of their lungs and therefore they have to, they might be more acidotic. Or let's say they've been suctioning gastric contents. Well, that means you're also suctioning gastric acid, which means they're more likely to be basic because they're losing an acid. They're more likely to be basic, and that can throw off the blood gas results as well. So those are all things that you just need to be charting. Charting will save your life. You need to chart what site you drew it from, the right radial, left radial, how many sticks you did, hopefully 1. Number of advances. So this is where you, how many times you advance. So you'll stick once, and then you're allowed to re-advance.
So re-advancing here is where you pull the bevel of the needle back to where it's still in the skin, so the needle's still in the skin, but now you sort of change the angle and you would advance again. So that would be 2 advances, right? So number of sticks, number of advances. You always need to chart a modified Allen's test results. Was it positive? Was there collateral circulation? So you want to be positive, right? You want a positive modified Allen's test. I'll repeat that again. You want a positive modified Allen's test. Yes. Positive is good in this situation. You always want a positive modified Allen's test. That means there's collateral perfusion. You always want to chart that you held pressure. If they're on anticoagulants, doesn't mean we can't do the blood gas. It just means you're probably going to have to hold pressure for a little bit longer. Usually it's a couple minutes, like 3 to 5 minutes in that area. It might have to be longer for patients that are on anticoagulants or low platelets. How much pressure and FiO2 they're on the ventilator or on the CPAP, BiPAP machine, how much pressure they're on. So those are all, we know exactly what was going on when this patient did this. So pressure, FiO2, so if they're on a nasal cannula 3 liters, remember our rules of 4, so 21, so 24 would be 1 liter, 28 would be 2 liters, 32 would be 3 liters, right? So you chart that at 0.32. That you applied some sort of dressing on the patient. You notice that after the procedure, they had good pulses. In other words, their hand had good perfusion. It's a good legal thing to chart that. Any complications, you're going to chart and hopefully let the team know if you do see that. So here's an example of blood gas drawn from the right radial after a positive modified Allen's test. 1 stick, 1 advance. Good job, whoever did that. Patient on a cannula at 2 liters a minute. Respiratory rate of 18, 37. So this would be 28% or 0.28. Pressure held times 5 minutes, right? 3 to 5 minutes. Good pulses above and below. Pressure supplied. No excessive bleeding or complications. This is something I need you to memorize. Right, not this specific example, but I need you to be able to chart everything or know everything that goes into charting the blood gas. Right. Obviously, you're going to put your name and your credentials in there as well. Capillary blood gases. These are more done in neonates, the NICU world. We love these up there. We don't have to poke in the arteries. We're going to just look at pH and CO2. So it's ventilation. Babies, the pulse oximetry is very accurate with little babies. So we don't really have to worry about blood gases for oxygenation. We're more looking at ventilation with blood gas. And that's where cap gas comes in. So we're going to look at the pH and CO2. And there's an option of also looking at transcutaneous where we put this little electrode, and then your books do talk about TCO2s. Electrode, and it looks at CO2 on their skin as well as PO2. So pulse oximetry and capnography are unreliable. We can also do a cap gas, and with this, we're going to try to vascularize the capillary bed. So most commonly is going to be on the heel. And that's going to be a big thing, heel, or we can do the fingers in older kids, but usually it's going to be heel. We're going to warm the site up for a couple minutes to arterialize the skin. In other words, to get a lot of good blood flow there. It'll also vasodilate, which means we'll get more arterial type sample as well. Just got to be careful. That's why we can't trust the PO2 on this, because what happens when you add heat? It increases metabolism, and when you increase metabolism, you increase oxygen consumption. So that's why cap blood gas, we cannot look at PO2s. They're artificially low, or they're low because we arterialized, we increase the metabolism in that site. But usually it's not enough to change the pH and the CO2. So that's why we're okay with just the pH and the over here. So the lateral sides, you see they do not use this area, so in or outside of that heel, we'll switch between both feet as well. Usually we're going to warm it for a couple minutes. We're going to clean the site, and then we're going to have this little lancet that punctures the site. It's very shallow. It's similar to what they do for blood sugars. Then we're going to wipe away that first drop of blood.
and then hold the heel above the heart. So just hold it up a little bit. And then we're going to sort of just make sure that that blood is flowing. You're not going to squeeze the blood out. You're just going to make sure that the blood is flowing. You should fill up a little heparinized capillary tube. They're very, very small, and there's some resources on YouTube about this. The little bit of capillary tube there, very, very small. We air because that'll throw off the pH and the CO2, if you remember right. Even though we're not looking at oxygen, it'll throw off the pH and CO2. Then we put these heparinized cap tubes into a drop of blood. It should flow easily into the tube, those cap tubes, right? They'll just suck it right into it. We should get an adequate sample, and then we still put them on ice. We still chart everything before. So this is something that you'll do up in the NICU, and hopefully if you're at a clinical site and ask if they do cap gases, if you could see one. They're pretty darn cute. Complications, too much squeezing, you could easily bruise the extremity, and they can get little bruises and stuff. There's usually good correlation between pH and CO2 here. Like I said, we're arterializing that site, but it's not going to cause an excess there. Poor correlation between PO2, so that's why we're just going to use it for CO2 and for pH. I would remember that a cap gas, we do not look at oxygen, we look at CO2 and pH. Indwelling catheters, this is going to be arterial lines. So this is great for blood sampling. If we have to do a lot of different blood gas samples, then this is great because that means we don't have to repeatedly poke an artery, and poke it again, and poke it again, causing scar tissue and trauma and all that stuff. We can put in one needle, and then we take it out, and then we have an indwelling catheter that is in there, and so the needle isn't even in their skin anymore, it's just a catheter, and we can draw blood from that catheter repeatedly, every 2 hours, 6 hours, so on and so forth. This is usually only indicated to put A-line in. Big thing here is if we have to do a lot of repeated sticks, like someone in severe ARDS on a ventilator, and or someone with hemodynamic compromise. In other words, the blood pressure is super low or incredibly high, and we have to give them medicine to help their blood pressure in either way. That's what we're looking at there. So we avoid a lot of repeated sticks. It's great. Usually the radial and brachial sites are the most common place. Understand there are patients that will have a femoral A-line in place and they cannot bend at the hip. So their bed, if their head of bed needs to be elevated, their whole bed has to be straight. They cannot bend at the hip because there is a thing that would occlude their femoral artery if they bend at the hip. So just understand that. Central catheters, the central line, they're usually in the superior vena cava, either subclavian or jugular, IJEJ. And so this is good if you want to do a VBG to look at pH and CO2 or how much change there is. If you have to do a shunt equation, then if we don't have a pulmonary artery catheter, the Swan-Ganz, right? So if for some reason we do not have a Swan-Ganz in place, so if this is not an option, then you can easily draw, went all over the screen there. You can easily draw from the central vein. It's the closest place to the lungs, and still do a venous blood gas, an arterial blood gas, and then do all your shunt equations from there. Do expect me to have that on this next test. You will be doing all those content and transport equations again. Joy, I feel joy from it. All right. So when you're looking at the sites for palpation, you should be able to feel these on your own or your loved ones next to you. My wife was always like, "You were feeling my pulse," and we were at the theater or whatever, right? So the end part of the elbow, you should be able to sort of feel it, that medial side of the elbow. Hopefully you should be able to feel it there. Just straighten your arm and you should be able to feel it. Radial site. That's something that we'll be looking at too. The radial site, once you feel for the site, you're going to palpate it, and then you're going to wipe it clean, and then you're going to, of course, wear gloves, which this person is not doing. Heavens to Betsy. You're going to wear your gloves while you're doing this whole thing. You're going to palpate the site, you're going to clean the site, then you're going to perform the puncture itself, and so we'll get into that more later.